Welcome back to our Edu-PIC lectures, and today I will present one of the most important topics, not just in PICU but also in ICU like neonatal units or adult intensive care units. Our topic today is the abdominal compartment syndrome. Initially, let's start with some definitions here. The first definition, what is the intra-abdominal pressure? It's simply the pressure inside the intra-abdominal cavity. Normally will be close to 0 in self-ventilating patients and will be 7 plus or minus 3, like 4 to 10 in mechanically ventilated patients. When to say this patient has an intra-abdominal hypertension? When there is a sustained pressure more than 10. And when to say this patient has abdominal compartment syndrome? When we have sustained intra-abdominal pressure more than 10, like intra-abdominal hypertension, plus new or worsening organ dysfunction. What's the meaning of that? Like we have here the abdominal pressure is more than 10, and we also plus kidney failure or ischemic colitis or difficulties in managing the patient respiratory wise due to all of this factor due to intra-abdominal hypertension. Because we can have patients with temporary with increased intra-abdominal pressure, but at the same time coincidentally has a renal failure. So we cannot say in this patient that we have abdominal compartmental syndrome, but this organ dysfunction should be due to the increased intra-abdominal pressure. And we have two categories here, like primary intra-abdominal hypertension or secondary intra-abdominal hypertension. The primary will be due to abdominal pelvic causes, which is frequently will require surgical or IR intervention, and secondary due to systemic factor like shock or whatever we'll see in the next slides. Historically, people start to think about the increased intra-abdominal pressure causing problems from 1876, when they have concern regarding increased intra-abdominal pressure and this concern on the renal function and the urine output. Then from 1980s, when advancing the surgical treatment for neonates, with neonates with abdominal wall defects, start to think about lethal impairment of the pulmonary renal system due to the increased intra-abdominal pressure. Then people start to think the increased intra-abdominal pressure will cause a compression of the inferior vena cava and will reduce the preload to the heart and will affect the cardiac output, respiratory function, renal function, and the splenic organ function. Epidemiology, from the studies, many studies has been speaking about the intra-abdominal hypertension and abdominal compartment syndrome, and saying the intra-abdominal hypertension is 12% and the abdominal compartmental syndrome is different from 0.6 up to 9.8% in the pediatric intensive care population. So okay, we have unit with 8 patients. Which patient do we have to measure the intra-abdominal pressure? In all patients? No, we don't have to do that. There's waste of resources, but we have to do that in the patient with risk factors for increased intra-abdominal or for the intra-abdominal hypertension and abdominal compartmental syndromes. Which patient, which category of patients that have risk factors? We'll divide, as we said before, to primary, so we have the problem in the abdomen, or secondary, we have a systemic problem. The primary The first thing, let's imagine we have a cavity here. So the increased pressure inside the cavity will be due to the wall of the cavity is less compliant to any pressure, or the contents inside the cavity is increasing. So the wall of the cavity, like the abdominal wall, less compliant as the cases of gastroschisis or diaphragmatic hernia, or even sometimes we can see it in the abdominal wall edema due to patient with severe heart failure or severe sepsis with capillary leak, or increased interluminal contents as in patient of ileus or small intestinal intussusception, or increased like abdominal contents. This contents could be fluid, which will be like bleeding from trauma or retroperitoneal bleeding, can be from ascites, or can be tumor like Wilms tumor or Parkinson lymphoma, can be from organ transplantation like a child patient who was donated a kidney from like an adult patient. So we have to think about abdominal compartment syndrome, bowel obstruction or perforation, intra-abdominal trauma causing like edematous viscera, and the acute pancreatitis. Then the secondary we said before, due to systemic problem like shock, septic shock, toxic shock syndrome, cardiogenic shock, all these factors causing like capillary leaks and affecting the abdominal wall and also increasing the abdominal wall contents. Burn is also causing the capillary leak due to liver or kidney transplant and hydrops fetalis. And here we have like a slide showing how the trauma can cause both primary problem by causing bleeding inside the abdominal cavity and also causing a state of shock, which we said before will cause secondary abdominal compartment syndrome. And so let's think about what's the pathophysiology of the abdominal compartmental syndrome. What is the problem like? What will happen if the intra-abdominal pressure increase? So we have like, let's think about, we have a sick patient with a hypertension due to sepsis. So we give fluid resuscitation for this critically ill patient. So we now have a total body fluid third spacing loss, and we have edema of the wall, edema of the viscera, and accumulating ascites. So we will have elevated intra-abdominal pressure. Then we'll have the vena cava compression due to increased pressure on the wall of the vein. Then we'll have like reduced blood return to the heart due to the compression of this vena cava, because you can imagine if the intra-abdominal pressure is 20 and the venous pressure is 10 or something, so the vena cava will be compressed. So less preload, less cardiac output, then less perfusion to and the flow to the organs, then we'll have the multi-organ dysfunction. It can cause like multi-system dysfunction, as we said before. Respiratory can cause due to, because like by increasing the intra-abdominal pressure, it will compress the lungs from down, and we'll have like increased intrathoracic pressure, we'll have increase in the peak airway pressure, increase in the plateau pressure, and decrease of the functional residual capacity, and ventilation perfusion mismatch, and it can cause also basal atelectasis from the compression from the abdomen. And in the abdomen, as we just said, it can, if this, like, let's imagine we have patient post-laparotomy, so it can cause problems due to high pressure inside, from inside, so it will cause problems to the wound. And as we said before in the previous slide, it will be a vicious circle due to the multi-organ dysfunction, so you have to give fluid, and this circle will be repeated again and again and again, so it will cause abdominal wall, decreased abdominal wall compliance. Then also we'll have problems here in the abdominal in the gastrointestinal system. The first thing, like decrease perfusion pressure, abdominal perfusion pressure, because like the abdominal perfusion pressure will be map like the main arterial pressure minus the intra-abdominal pressure. So let's imagine this patient, which is like 3 years old with a maps of 50-55. It will be okay if this patient there is no like increase in abdominal pressure, but if this patient has an abdominal pressure of 20 or whatever, so now the perfusion pressure will be like 35, so it will not perfuse the intestine. So it can cause like neck or necrotizing enterocolitis in young infants, or can cause ischemic colitis. It can cause also increased intestinal permeability and increased bacterial translocation. And here in the lower limb, due to the compression of the vena cava here, so we'll have venous stasis, increased risk of DVT, and then the renal system. This is one of the most common problem. The same as the gastrointestinal system, will have like decreased renal perfusion pressure due to increased intra-abdominal pressure, and will also have like venous stasis, like renal vein stasis, due to the compression of the inferior vena cava with decreased filtration gradient, and so low urine output, oliguria or anuria. The same to the hepatic system, decreased flow and decreased lactate clearance, and decrease in the mitochondrial function. Then cardiovascular system will be increased in the RV overload due to the lung problems that we said before, and also due to decrease in the preload, decrease in the venous return. So less filling, more afterload to the RV, so more failing heart and less cardiac output. And the CNS also can cause like increase in intracranial pressure and decrease in the cerebral perfusion pressure. And now we are coming to how to measure. But before saying how to measure it, let's say like there is two different opinions. There's some opinion or like some people saying you don't have to measure, you have to go with a clinical judgment. So if we have like a patient with, as we said before, with a primary cause or a secondary cause with like abdominal wall edema, with ascites, and now there is decreased urine output or difficulty to ventilate despite the lungs has been fine, or low cardiac output picture, so we have now high suspicion of abdominal compartmental syndrome. So some people say, okay, no need to measure. We have now high clinical suspicion, so we can just go with a treatment without measurement. And some people say, let's measure, let's have like a baseline measurement. Then after doing the management, as we will see in the next slide, we can do like the another measurement and see how the trend. So how to measure, like basically we'll see in the next slide, but through the urinary catheter, it has to be done at the end of expiration. Abdominal muscle contractions are absent. The transducer zeroed at the level of the mid-axillary line. We'll see like in details in the next slide. Then the transducer have to be open to the bladder, to the urinary catheter, and to be closed to the urine collection bag. We'll see. Then they have to give saline with a rate of 1 ml per kg with a minimum of 3 ml and maximum of 25 ml of sterile saline. Then we have to take serial measurement if we are going with a measurement like every 4 to 6 hours. 6 hours. So here is the urinary catheter inside the patient, coming here to the connection, one part going to the collection bag and the other part going to the transducer and to the cable here. Then this is the saline flush that we said, like 3 minimum and 25 maximum. Then we come now, so we have patient now with intra-abdominal hypertension or abdominal compartmental syndrome. What we have to do, as any management, first thing we have to treat the cause, to break the circle as we can. And second thing, we have also to put in mind to optimize the organ perfusion, because as we said before, the perfusion pressure now is different from the maps, because normally we'll set the map target is 50, this patient is okay for like 2-3 years old, or like whatever the target to the age of the patient. Now we have to put other targets because like we have to optimize the organ perfusion, and the main management will be adequate monitoring and recognition of the problem, to do it every 4 to 6 hours, then medical management, then surgical management. How medically will be the same, like to think about like first thing to we have like a cavity now. We will try to improve the compliance of the wall, then we'll try to decrease the intracavity contents. First thing, like to improve the wall compliance, we have to give adequate sedation and analgesia. We have to give muscle relaxation if we have to, and we have to avoid elevation of the head of the bed more than 30 degrees. Then we have to evacuate interluminal contents by nasogastric or rectal tube. We have to evacuate the abdominal fluid collection if we have like significant ascites by paracentesis, by percutaneous drainage. We have to correct the fluid balance, so to target negative balance as like if the patient like now more stabilized and we don't have to give like fluid resuscitation at the time, so we have to use dialysis or whatever like to achieve negative balance. Then optimize the organ support, and we have to put in mind that the plateau pressure, transmural pressure here will be the plateau pressure minus the intra-abdominal pressure. So if the plateau pressure now is 30 and the abdominal pressure is 20, so it will be like 10 plateau pressure. So we have to increase in this patient, and also to think about the preload indices, like because we're now measuring the CVP. The CVP transmural here will be different from the usual CVP in other patients, because like if the abdominal pressure in this patient is 20 and we have CVP reading of 10, so it will be 10 minus 0.5 multiply the intra-abdominal pressure, which was 20, so 10 minus 10 will be equal 0. So we have to give this patient more filling. Then if the medical management is stuck and the patient is deteriorating with more organ dysfunction, so we have to think about the surgical management. First thing, sometimes if we cannot do the percutaneous catheter drainage to the fluid, so the surgical team will do it, to use the compressive laparotomy if we have to, and if we have abdominal wound, to use negative pressure wound therapy. As this will be in agreement with the surgical team, of course. And here we have like the diagram or algorithm is mainly from like adult intensive care unit, but here we can apply also. So we have now patient with intra-abdominal hypertension or abdominal compartmental syndrome with increased the intra-abdominal pressure is more than 12. It's usually like give grades, but will not make big difference like grade 1A, 1B, 1C, like according to what is the reading, but it's not quite important in the pediatric population. But we have a patient of increased like intra-abdominal hypertension. So the first step, we have to evacuate the interluminal contents by using the nasogastric and or the rectal tube. And also we have to evacuate intra-abdominal space from any occupying lesion, which can be fluid, which can be solid mass, or whatever the cause. So here we have to identify by using the ultrasound to identify the lesions. Do we have ascites? Do we have significant ascites? Do we have like Wilms tumor in this patient? And we have to improve the abdominal wall compliance by using adequate sedation and analgesia, and remove constrictive dressing if this patient from the abdominal surgery and there is abdominal constrictive dressing. So we have to remove it in this patient or to put in mind, and optimize the fluid administration, avoid using excessive fluid resuscitation, and aim for 0 to negative balance. And to monitor also and optimize systemic and regional perfusion by goal-directed fluid resuscitation. Then step 2 will be by minimizing the intra-nutrition. So now we have to think about stopping the intra-nutrition, administer enemas if we have to. Then we have to use CT or percutaneous drainage of the abdominal contents. We have to consider reverse Trendelenburg position with the head down, resuscitate using hypertonic saline or colloids, and fluid removal through the diuresis or dialysis if we have to. But here mainly with the diuresis in step 2, then continue also the hemodynamic monitoring. Step 3, consider colonoscopic decompression and discontinue now, not to consider, no, stop the intra-nutrition, consider surgical evacuation of any lesion, and consider muscle relaxation, consider the hemodialysis. Step 4, if the intra-abdominal pressure more than 20 and the new organ dysfunction or failure, so this patient is refractory to all the medical steps that we have tried before in the previous steps, so strongly consider surgical abdominal decompression. And thank you so much for listening to this topic, and hopefully we'll meet you again in the next topic in the next days. Thank you so much.